Hello again. So this is, as far as when I'm making these videos, this is the very beginning of the much awaited obstetrics and gynecology series, which I hope to get these done timely. However, I'm particularly busy at this point in time, so I might not be able to get these out as quickly as I want to, but it is a work in progress, so hopefully you are satisfied with these. We're going to talk about the urinary tract here, the anatomy and physiology of the urinary tract, primarily focusing on the bladder and the urethra. And this is sort of a preface to some of the most common urinary tract disorders in women, apart from urinary tract infections, and that is the urinary incontinence disorders. Now, certainly you can see urinary incontinence in men, and you do see urinary incontinence in men, particularly the obstructive problems, which can lead to overflow incontinence, and you see that in men because of prostate enlargement. But these are, by and large, more common in women than in men. So, we're going to talk about the anatomy of the urinary tract, just some very rudimentary basics. We'll talk about the physiology. I want to spend most of our time talking about that here because understanding the physiology is going to be very important when we talk about how we go about treating these disorders pharmacologically, even whether or not we can treat these disorders pharmacologically. We'll talk about the voiding diary, which is good to know. It's kind of self-explanatory, but it's good to have a voiding diary, teach a patient how to do a voiding diary because the history is going to be very important in formulating a presumptive diagnosis when it comes to these incontinence disorders. And then we'll also talk about the pharmacologics. I'm not going to go into too great of detail there because we'll talk about pharmacologic management as we touch on each of these respective urinary incontinence disorders. So the female urinary tract, basically it's going to be the same as the male urinary tract with the exception that you have different organs surrounding it and different organs not surrounding it. So the female urinary tract, the bladder sits anterior to the uterus, and that's obviously something that you don't see in men. Now, the fact that these two are close gives a couple implications that come to mind right away. First of all, when you're pregnant, the baby is inside the uterus, it's going to push on the bladder, the woman is not going to be able to hold as much in her bladder, and that's why women who are pregnant, particularly further along in their pregnancy, they have to go to the bathroom much more. It's not necessarily because they're making as much urine, or more urine, it's more so the fact that their bladder just can't hold as much. So that's one obvious implication. Another implication that's important, and this will come up as we talk about these incontinence disorders, is that you can have fistulas between the bladder and the vagina or between the ureter and the vagina. And we call these vesiculovaginal fistulas and ureterovaginal fistulas. And these tend to happen in developing countries because of hysterectomies, but they can happen due to any kind of pelvic surgery, especially if the woman already has something inflammatory in that area already, like endometriosis or pelvic inflammatory disease. They do also happen in the developing world, and that tends to be due to traumatic pregnancies. And so we will talk about that when we talk about bypass incontinence, which looks a lot like overflow incontinence, but there's fistulization between the bladder or the ureter and the vagina. Another thing that will be worth noting is, well, first of all, and this applies in men too, but you have kidneys, which connect to the bladder via the ureter, and then that in women you don't have a prostate, obviously, and then that's going to come out into the through the urethra into the urethral orifice, which you will note on a woman if you look at the external anatomy is going to be superior to the vaginal inlet and ultimately the cervix. So it's kind of hard to appreciate that here, but well, if you look at this, it's kind of like the right leg here is cut off. You can see that the opening of the urethra is superior to the vaginal tract. All right. So this is looking inside the bladder. As you know, you have ureters coming down, opening up into the bladder. That's how you get your urine down from the kidneys. And then you have an outlet here, which you have an internal urethral sphincter. This is smooth muscle, so this is involuntary, and then the external urethral sphincter, or the urogenital sphincter, this is striated muscle. And so this is voluntary, and this is how you control when you urinate. So when you urinate, you are relaxing the external urethral sphincter. The urogenital sphincter is composed of 3 different components. The sphincter urethrae, which wraps circumferentially around the urethra, and then the urethrovaginal sphincter in women, and compressor urethrae. And these arch ventrally over the urethra and insert into fibromuscular tissue of the anterior vaginal wall. So that is your voluntary component, and that's obviously going to be, therefore, innervated by the somatic nervous system, whereas most of the components of the bladder, the detrusor muscle, the neck of the bladder, they are innervated by the autonomic nervous system, as we're going to see. All right, so this is just a schematic of the bladder. These 2 little dots here are just where the ureters come in. So we have up here the bladder dome, and then the detrusor muscle in red here. The bladder neck is sort of your more distal, inferior part of the bladder. The pelvic floor, which is musculature, and then distal to the pelvic floor is the urethra. Now you have different receptor types that are related to the nervous system, and they're going to do different things. So in the bladder dome and the detrusor muscle, you have muscarinic receptors, which are part of your parasympathetic nervous system, and then you also have beta-adrenergic receptors, which are going to allow the smooth muscle to contract, and that's going to be on the detrusor muscle. So when you think of it, the detrusor muscle is smooth muscle, and you have beta receptors there. Where else do you have smooth muscle that have beta receptors? In your bronchi. And it makes sense that when the beta receptors are activated, like by beta agonists, the smooth muscle relaxes. And that's why you take beta agonists for asthma. It's a bronchodilator. It allows the smooth muscle to relax. And it's going to work the exact same way with the detrusor muscle. When the beta adrenergic receptors are activated, the detrusor muscle relaxes, and so the bladder is going to become more compliant. And that is going to be favorable if you want to retain urine, if you don't want to urinate. Now the muscarinic receptors, they do pretty similar things. So they're going to, when they're activated, they are, well, it works sort of opposite. When they're activated, they contract the bladder. And when they're unactivated or inactivated, they are going to relax. And the muscarinic receptors are parasympathetic, so they're activated by acetylcholine. The beta-adrenergic receptors are sympathetic, so they're going to be activated by norepinephrine and epinephrine. Okay, and then the bladder neck and the urethra are innervated by the sympathetic nervous system, and they have alpha receptors. And when the alpha receptors are activated, they constrict. Okay, so why is it that the beta-adrenergic receptors relax and the alpha-adrenergic receptors cause constriction? Doesn't that sort of work in opposite directions? And the answer to that is no. So when the beta receptors are activated and they cause relaxation of the bladder dome. So they're going to allow the bladder to become more compliant. And that is good if you don't want to urinate, because you don't want the pressure in your bladder to go up. If the pressure in the bladder goes up, it's going to favor urine leaving the bladder. Now, on the other hand, in the bladder neck and the urethra, if you don't want to urinate, you want that closed off. Because if the urethra is open, then it's going to favor urine leaving the bladder, because you have a high pressure gradient between the bladder and the urethra. So the alpha adrenergic receptors along the urethra and the bladder neck, when they are activated, they constrict. And that is going to favor urinary retention, not urination, because the urethra is closed off. And here, namely, when we're talking about the urethra, we're talking about the urogenital sphincter, the external urethral sphincter. So what this does, if you combine the two of these together, the alpha adrenergic receptor is going to increase the intraurethral pressure because it constricts, while the beta adrenergic receptor is going to favor relaxation of the bladder dome, and that is going to increase the intravesicular pressure, the pressure inside the bladder. And ultimately, what that does is it increases the pressure gradient, where you have a lower pressure in the bladder and a higher pressure in the urethra, and that is going to favor retention, because when you want to urinate, you want a low pressure in the urethra and a high pressure in the bladder. This is just the opposite. So the sympathetic nervous system is going to favor urinary retention, because you reduce the pressure in the bladder via the beta receptors and you increase the pressure in the urethra via the alpha receptors. And so anything that activates the sympathetic nervous system, anticholinergics, is going to favor retention. On the other hand, the parasympathetic nervous system, you have these muscarinic receptors, and you also have nicotinic receptors. That's going to be important when it comes to the external urethral sphincter, but we're not going to talk about that right now. We're going to talk about muscarinic receptors. These sit on the detrusor muscle and the bladder dome. Now, this works the exact opposite of the beta receptors. The detrusor muscle is going to be activated by these muscarinic receptors. Now, this is part of your parasympathetic nervous system. So these are activated by acetylcholine. And so when these are activated, these muscarinic receptors are activated, the detrusor muscle is going to contract. And what is that going to do to your intravesicular pressure? It is going to raise it, because the detrusor muscle, by contracting, it shrinks the bladder and it increases the pressure. All right, so then you have these nicotinic receptors, which are along the external urethral sphincter. This also is activated by acetylcholine, but this is part of your somatic nervous system. And so this is all under conscious control. But this is also activated by acetylcholine, just like the detrusor muscle is. And so this will cause constriction of the external urethral sphincter. Remember, though, that this is a voluntary process. So when you relax your external urethral sphincter, you are ending this conscious tonic activation of this sphincter where it's constricted. So that's important too, to remember that this is a tonically activated sphincter. So when you're urinating, you're actually relaxing the sphincter. You're not constricting anything. Normally, when you think of conscious process, you think of constricting or tightening. That's not so here. When you're consciously relaxing the sphincter, you're relaxing it, you're not constricting it. Okay, so that makes sense, because what happens when you relax, you reduce the pressure. And when you reduce the pressure in the urethra, you increase the pressure gradient from the bladder to the urethra, where the bladder has a higher pressure, the urethra has a lower pressure, and that's going to favor urination. Okay, so this is all going to be important when we talk about drugs. We'll talk about that in a little bit. So these are the nerves that go to the bladder. So we already talked about how there's muscarinic and beta receptors on the dome of the bladder. The muscarinic receptors, of course, are part of your parasympathetic nervous system, S2 through S4. The beta receptors are part of your sympathetic nervous system. This is a little bit higher up in the spine. This is L1 through L3 via the inferior mesenteric ganglion and hypogastric nerves. Now, the part of the bladder that is under conscious control, remember, is the nicotinic receptors of the external urethral sphincter, and that is under somatic control, S2 through S4. Remember, S2, S3, S4. S2 through S4, get your pants on the floor. That's pudendal nerves. That also does some of the genital stuff too. But when this is damaged, then you're not going to be able to have your external urethral sphincter under tonic contraction. And what that means is that you're going to lose all your continence. And so when you have damage to the pudendal nerve or to the S2 through S4 nerve roots, then you lose continence for that reason. Okay. So this is a voiding diary. Now, when you have a patient who complains of incontinence, most of the time by getting a decent history, if she can relate to you these things, if she remembers, just by getting a clinical history, you will be able to pinpoint what type of urinary incontinence it is. However, in more complicated cases, or in cases where you want to treat the woman conservatively, where you want to see if maybe she's doing some things that might be aggravating her condition, then having one of these voiding diaries can be useful. So for instance, this particular woman, 7 a.m., she woke up, she needed to go to the toilet. 7:30, she needed to go to the toilet again. 8 a.m., this is what she ate and drank. Mostly we're concerned about what she drank. So she had some grapefruit juice and some tea. That's good. 8:15, she had to urinate again, 100 milliliters. 8:25, she had to urinate again, 50 milliliters. 9 a.m., she was a little bit incontinent, passed about 50 milliliters. 9:15, incontinent again. 9:30, passed a few drops. Bladder feels jumpy. So what do you have here? Well, first of all, you definitely have urgency because you are going to only normally urinate 8 times a day or less, assuming that you're drinking the normal amount that you're supposed to drink. Obviously, if you're drinking a lot of fluids, then you're going to urinate more. But in the span of only 2.5 hours, she's needed to urinate once, twice. I don't know if this is where she lost urine, but she's had to urinate at least twice in an hour. So this is definitely some urgency going on here. There's also incontinence, and then the fact that she's dribbling, that suggests a stress incontinence. So you have both what looks like an urge incontinence here and a stress incontinence. This is probably that mixed incontinence, but we're going to talk about this in greater detail in future lectures. I just want to quickly bring up some of these basic urometrics, and the normal bladder residual is around 50 mils, and so normally it usually takes up to about 400 milliliters to where you're going to feel the urge to void. The bladder typically holds around a liter, maybe a little bit more at its maximum. But it's generally not going to be until about 400 milliliters of urine where you're going to feel the urge to urinate, where you really decide you probably want to go to the bathroom now. If you're feeling the urge to urinate much less than that, when it's maybe 100 or 150 mils, then that's urinary urgency, where the threshold to where you feel the urge to urinate is lower. And so this woman, she felt the urge to urinate at 100 mils, and then she felt the urge to urinate again at 50 mils. Now, technically, you would want to know what the post-void residual is, because that 100 mils might not be all the urine she has inside her bladder at that point in time. But assuming that she has a normal post-void residual, which is roughly around 50, then we can assume at this point she has no more than 150 mils of urine in her bladder. And that would be consistent, if she had the urge to urinate at that point, that would be consistent with urinary urgency, because she does not have that 400 mils that you normally would have the urge to void at that point. Okay, but this is all going to be reliant on knowing the post-void residual, and that's why when you have somebody with urinary incontinence, you want to know what the post-void residual is. Because let's say she had a post-void residual of 400 milliliters. Then it's going to make sense that she wanted to urinate at this point at 8:15 a.m. because she has 500 milliliters of urine in her, a half a liter. And remember, the urge to void typically comes on around 400 to 500 milliliters. So that would change our diagnosis. If she had 400 milliliters of post-void residual, then this is not urinary urgency. She has having a normal response to the amount of urine she has in her bladder. What she may have in this case then is a detrusor hypoactivity, where she can't constrict her bladder enough to get all the urine out, or maybe she has an obstruction. So it's important to know the post-void residual in all of this. You can't just make a diagnosis with a voiding diary alone, but you can generally get a pretty good idea. Okay, that's the voiding diary. That's always going to be part of your general workup when you have a patient with incontinence. But in many cases, you will be able to make a presumptive diagnosis even without this voiding diary. And I don't think you're going to have a voiding diary like this on the USMLE. What you will have is something in this sort of form in the patient vignette. So the drugs that are used in urinary incontinence include anticholinergics. Remember, anticholinergics are essentially sympathomimetics, and the sympathetic nervous system favors urinary continence. So this is something that we give to patients to make them more continent. So in the case of overactive bladder, urge urinary incontinence, detrusor hyperactivity, we give anticholinergics. Now, this is not going to be as useful when we're talking about stress incontinence, where typically the problem is more anatomic rather than neuromuscular. But we do give these for overactive bladder and urge incontinence, and what these serve to do is, one, relax the detrusor muscle, and then they also increase the tone of the urethra. So drugs in this category include propanthyline, oxybutynin, tolterodine, fexofenadine. These latter three drugs also have muscle relaxant properties. Now, something to keep in mind is that drugs that work the opposite way, so alpha blockers, so going back here, here we go. So what would an alpha blocker do? So an alpha blocker like phenoxybenzamine or prazosin, an alpha blocker would restrict your ability to constrict the urethra. And so in other words, what that would do is essentially relax the urethra, meaning that you would be less continent. And indeed, phenoxybenzamine and prazosin, one of the adverse effects is urinary incontinence. Okay, so just kind of understanding this physiology gives you an idea of what some of the adverse effects of various drugs may be. Tricyclic antidepressants. So the one we're talking about here is imipramine. What does a tricyclic antidepressant do? Well, it has some alpha adrenergic activity. If you look at the biochemistry of these tricyclic antidepressants, you'll see that they do have alpha adrenergic activity. That is going to allow actually, this should be the opposite way, relax dome and constrict urethra. And that's going to help with stress urinary incontinence and urge urinary incontinence. Okay, so essentially what you do here is you're going to cause constriction of the urethra, and that's going to help, and relaxation of the dome, and that's going to help when it comes to incontinence. Okay, so this should say relax dome, constrict urethra. Okay, and then the cholinergics. Why would you ever want to give cholinergics in the event of incontinence? Well, there is one kind of incontinence where you do want to give cholinergics. Cholinergics would make you urinate. And there is a form of urinary incontinence where you are incontinent because you can't urinate. And that would be overflow urinary incontinence. So you're unable to contract your detrusor muscle, you're unable to urinate. What happens? The bladder becomes full of urine, and eventually it's going to just dribble out. Your bladder is not going to explode. What's going to happen is urine is going to just dribble out once it becomes so full it can't hold anymore. And so a cholinergic drug that will strengthen the detrusor muscle and allow you to get that urine out will help with that overflow incontinence, because now you'll be able to voluntarily get that urine out, and so you'll no longer have all that dribbling because the bladder can't hold anymore. You'll be able to get the urine out. This is useful for patients who after surgery have some difficulty in urinating. By giving them a cholinergic like bethanechol, they'll be able to, their detrusor muscle will be able to contract better, and so they won't get that overflow urinary incontinence. So this is what we give that for, and we'll talk about that in greater detail as we go on. Okay, so this is just kind of, and you don't need to know this now, we'll talk about these all in greater detail, but you can see some of the things that we want to know about our patient as far as their history. We want to know, is there increased frequency? So are you going more than 8 times a day or more than 2 times a night? Is there urgency? Are you able to void voluntarily? Do you lose urine with the Valsalva maneuver? So coughing, sneezing, laughing, anything that increases abdominal pressure. How much do you lose when you're incontinent, and do you have nocturnal symptoms? All part of your history. As far as part of your physical exam, you want to know about the S2 through S4 reflex. Namely, here we're talking about the bulbar cavernosus reflex, which is where you stimulate the labia majora and you look for contraction of the anus. And then urinalysis is going to be part of your basic workup for any urinary incontinence, because one common cause of urinary incontinence is bladder infection. Q-tip test we'll talk about when we talk about stress urinary incontinence. Urodynamics, we'll just briefly touch that when we go over all of these, and then the management. But again, we'll talk about this in greater detail as we go into each of these incontinences. All right, so I will see you in the next section.